Hello, good morning, good afternoon, good evening, wherever you are. Welcome back to the channel and thank you for joining us. We have a very interesting topic for discussion today, and I have a special guest, Dr. Usha Nandini. She is a fetal medicine expert. She currently works in Thanjavur, and she trained in India as well as in Australia, Sydney, Australia. She is very experienced in various aspects of fetal medicine, and as most of the concerns that the parents face, as well as the questions that some of the pediatricians face, are related to soft markers during the pregnancy screening. We are going to focus our discussion on that. She has kindly agreed to do a brief presentation on this topic, followed by a discussion on how we can guide parents on what to do next. So some of these are not easy, and obviously the evidence base is going to keep updating as we get more evidence or more information on these topics. So please update yourself on these as well as we go on. Dr. Usha, as well as her husband, Dr. Maniram Krishnan, he's a pediatric cardiologist. They have both started a venture called TINY HEARTS, and in Thanjavur, they are doing it as a charitable service as well. And I'll share the details of their work and the trust they run to support poor parents in terms of either antenatal fetal concerns or even cardiology-related problems. They're doing a creditable job, and good luck to both of you. And thank you for joining, Dr. Usha.
Thank you very much for the lovely introduction. So it's a pleasure to participate in this meet. And I'm happy to clarify all the doubts and whatever you want me to ask. I'm really happy.
Thank you. Yes, in the past 15-20 years, routine antenatal screening, risk factor-based approach has become almost the norm. So except in probably the rural parts of India, any urban center, the parents are referred for anomaly screening. So you have the dating scan and then the anomaly screening, the pregnancy related tests, like the double test and triple marker test, and all are ordered as well. And do you think this is leading to more anxiety in the parents? We do pick up significant findings and we can refer them to the appropriate center, but especially the question of soft markers, it does generate a lot of anxiety in the families, right? How do you put the cost benefit or the anxiety versus the benefit to the baby in terms of outcome in these soft marker issues?
Yeah, definitely I do agree with you that it puts some degree of anxiety for the parents. And because most of the referrals, especially I work in a unit where most of them come for a second opinion and with some major problems or minor problems and all those. So definitely parents are very confused when they come, especially features like echogenic intracardiac focus and renal pelvic ectasis. They're very anxious and they come for opinions. But I think in a way it is good that we are able to pick up Down syndrome, and I think the only way to pick up chromosomal abnormalities in utero is a strong ultrasound protocol. So I think if we are clear with our concepts, and if the imaging specialist is clear with what he or she is seeing in the ultrasound, and if the imaging person knows what to do next, then I think the job is easy. So most of the anxiety also adds up when the scanning doctor or scanning person doesn't have a clear idea of what has to be done next. So that's why I always insist any unusual marker or finding in an ultrasound should be referred for a proper fetal medicine expert's opinion, so that they can guide them in a proper way, counsel them in a proper way. And as you said, it's all about the outcomes. So generally what I feel is most of our screening protocols are getting better, and people are getting trained in ultrasound. They're able to do reasonably good NT scans, anomaly scans, and all those. And we need to focus on the outcomes of the babies rather than just sticking to the abnormality part.
The problem we have here is that the outcomes are mostly unpredictable at that early stage. And you are absolutely right. The counseling part from the person doing the scans is very important, appropriate counseling. So the persons practicing this should be well versed in communication in an empathic way and understand the parents' anxiety and answer all their questions, and also acknowledge with some humility that there's a lot of unknown here. I mean, and obviously when it comes to the heart, for example, heart is a vital organ, everyone understands that, but the echogenic focus doesn't mean anything by itself. So we know that it's going to disappear, and it doesn't mean, unless in rare cases where you may have endocardial fibrinostosis progressing. So repeat scans are important, but most of the time the echogenic focus doesn't itself translate. It's a soft marker of something else, and you're also looking for it through other means. So this particular aspect, that the organ itself is not really abnormal unless we have further concerns on repeat scanning, should get across. And the point you made on communication is very important, and communication skills have to be inculcated when an obstetrician or a radiologist gets trained in fetal medicine, because this is like most families focus so much on their baby's health, in utero health, and it's a lot of uncertainty. And we know that stress during pregnancy can affect the fetal outcome as well as lead to prematurity, or some studies even show increased risk of autism if the mother is psychologically upset during the pregnancy. So all this have to be taken care. And I mean, I know overseas training does bring in a lot of change in the way we communicate. So you are lucky to have that as well. But in terms of colleagues who are watching this, please discuss with your obstetric colleagues as to the importance of communication, because most of the answers to these questions are not as clear cut as we would want. And so a clear communication is important. So now I would request Dr. Usha to share her screen and go through a brief presentation. We will then discuss on questions. I can see your screen. Please start. Thank you.
Yeah. So this is going to be the overview of my presentation for the next few minutes. So what is soft marker and fetal ultrasound, and what are the soft markers which we are trying to look at? Especially, we are going to focus in a second trimester scan between like 18 to 22 weeks or from then on. And why is it significant, and how is it going to be significant? And the most important thing is how are we going to follow these babies, let it be antenatal period or the postnatal follow-ups. So I think we can classify the abnormal fetal ultrasound findings as major congenital abnormalities. Most of the time we know like what is going to happen when there is a major systemic abnormality in a fetus. And there could be minor congenital abnormalities, or in other words, soft ultrasound markers, especially soft ultrasound markers for aneuploidies like Down syndrome trisomy 21. And there is a third category where the finding is not normal, and which means it is not present in all the fetuses, but still it could be a normal variant, or sometimes it can be a transient finding which would disappear during the later part of the gestation. So we are going to focus on the soft markers, and let's see like how it is going to be important, not just in the chromosomal abnormality aspect, and what is beyond that as well. So some of these minor findings are always confusing and puts more anxiety to the parents. And there's a huge list which keeps changing now and then, based on the available evidence. And let's see what we usually follow in our clinical practice with this regards. So I always feel that it's a cakewalk for a neonatologist or a pediatrician to diagnose a Down syndrome. So the moment they look at the baby, they're going to tell that it's Down syndrome. But whereas for a fetal imaging person, it's not straightforward. And that's why we have developed a lot of ultrasound markers, the screening protocols, the maternal screening protocols from the bloods. We look at the hormones. We isolate the DNA, the fetal DNA from the mother, and we do all those kinds of tests. The essence of all these effort is to find out whether a baby has got Down syndrome and whether this can be diagnosed in the antenatal period, so that it's really going to help the family and of course the society as well. So this is a list of soft markers in the ultrasound, which we try to look at in all the second trimester fetuses. And when we see this, The moment we see this, the first thing which strikes us whether we have to evaluate this baby further to look for presence or absence, or to rule out Down syndrome. So generally, when there are 2 or more markers, we do recommend direct fetal testing, by which I mean that it's amniocentesis, to put a needle in the mother's womb and draw some amniotic fluid and send it for testing and to confirm whether the baby has got a Down syndrome. First on the list is the choroid plexus cyst. Choroid plexus cyst is nothing but entrapment of the CSF in the growing ventricles, and usually it regresses as gestational age advances. So it can be single, it can be multiple, it can be unilateral, or it can be bilateral. Generally, when it is isolated, by isolated I mean that there is no other additional marker or additional finding in the ultrasound, and the screening is also low risk. The maternal aneuploidy screening is also low risk. Then we call it as, when it is an isolated finding, the neurodevelopmental outcome is expected to be completely normal. So next is the lateral ventriculomegaly. Ventriculomegaly means the dilatation of the lateral ventricles, either right or left, or it can be both. The important point here is the measurement must be accurate to label whether the baby has got a mild ventriculomegaly especially. So the cutoff, accepted cutoff, is more than or equal to 10 millimeters in 2nd or 3rd trimester. And it can be mild, moderate, or severe. Obviously, when it is moderate and severe, it's going to be pathological. And the way we follow up these fetuses and evaluate is going to be completely different. And the cause is totally different for those babies. Whereas when it is mild, it is considered to be a soft marker for trisomy 21 or aneuploidy. So the causes for this ventriculomegaly includes chromosomal abnormality, genetic problems, or fetal infections. If we are certainly able to rule out all these, and still if it is an isolated mild ventriculomegaly, which is say like 10 millimeters for a baby till term, then we can just follow up these babies postnatally. And evidence says that there is a small risk of neurodevelopmental outcome, but most of them do well when it is isolated and it is still mild. So always we recommend postnatal neurosonogram for all these babies also. And a proper counseling and further testing is very important when we come across mild lateral ventriculomegaly. So next is the nuchal fold thickness. And one important point I'd like to emphasize is this is not synonymous with nuchal translucency. Nuchal translucency, or NT, is usually it's measured in the 1st trimester between 11 to 14 weeks, whereas nuchal fold thickness is being measured in the 2nd trimester. Again, this is also a redundant skin at the back of the fetal neck, but it is being done in the 2nd trimester. So general accepted cutoff is more than or equal to 6 millimeters. And this is considered to be a strongest marker for in the 2nd trimester. And I would recommend further evaluation in these fetuses to rule out chromosomal abnormalities. So absent or hypoplastic nasal bone is one more important finding in the ultrasound, which really adds more anxiety. Most of the parents ask whether it means that it's the absence of the nose, but we know that it is just the ossification of the nasal bone which is being affected. And it can be hypoplastic. By hypoplastic, we mean that there are some expected measurements which vary with the gestational age. There are several normograms for this, and it varies with various races as well. And when it is smaller than expected, when it is less than 50th centile for the period of gestation, we call it as hypoplastic nasal bone. Regardless of whether it is absent or hypoplastic, an unoccupied nasal bone is strongly associated with chromosomal abnormality, not just Down syndrome. Even now we see that more of even microdeletions and microduplications, and some of these pathological CNVs could also be associated with hypoplastic or unoccupied nasal bone. We should also counsel the parents that when we do not see the nasal bone in the 2nd trimester, like say like 18 or 20 weeks, it's very much possible that the ossification could happen during the later part of the pregnancy. Regardless, the clinical significance remains the same. So if I see an unoccupied nasal bone in a fetus in the 2nd trimester, I'm not going to wait to see whether the nasal bone grows and then counsel the parents. I would immediately counsel the parents tell them that nasal bone is not ossified, and I will also explain the need for further evaluation for these babies. Echogenic intracardiac focus is one of the most commonest causes for referral, and being in a pediatric cardiac unit, I do see these kind of referrals very often daily. So this is nothing but a bright echogenic spot in the fetal heart. So it can be present in the left ventricle, right ventricle. It can be single, it can be multiple. It can be located in any part of the ventricle, and 90% it disappears during the later part of the gestation or postnatally. And when it is isolated, it does not increase the risk for chromosomal abnormality. When there is an additional marker in the fetal ultrasound, or when there is an abnormal aneuploidy screening report, yes, we do give significance for this finding. Otherwise, it is actually an innocent finding, and we do not even recommend postnatal follow-up for these babies unless the parents are really very anxious, or we expect something else in the baby postnatally. One important point again I would like to tell here is, whenever we come across echogenic intracardiac focus, I think it's very, very important to subject these fetuses for a proper detailed anatomical survey, as well as for a proper fetal echocardiogram, because sometimes there could be some other associated findings which might be difficult to be picked up by normal imaging scans. So there could be some VSDs, or there could be some other small findings which might be really difficult to be picked up by the routine scanning specialists. So next is aberrant right subclavian artery. This is again one of the common aortic arch abnormality. It's a developmental error, and this can be picked up during first trimester, second trimester, or third trimester. There is evidence to say that this could be associated with trisomy chromosomal abnormalities, and with, of course, chromosomal 22q11 Dijot syndrome microdeletion as well. And again, when we see this, I think we should see to that these fetuses get scanned by a proper fetal cardiologist or a proper fetal medicine person to rule out any other associated problems. We need to bear in mind that this could potentially be a vascular ring as well. So all these babies definitely would require postnatal echocardiogram by a pediatric cardiologist. So hyperechogenic bowel is nothing but the small intestines look brighter than it has to be. So we compare the echogenicity with the bone echogenicity. So here in this picture, we can see that the bowel loops here are brighter than it has to be. We can see that the adjacent bowel loops aren't that bright, and we can see that the brightness is almost as the bone in the fetal bag. So again, when we see this, we need to make sure whether it's an isolated finding or whether there is an associated abnormality. Here, we need to also look at the bowel loop dilatation, whether the small intestines are dilated, whether there is any ascites, whether there is any other additional findings in the abdomen. And if it is isolated, again, we think of chromosomal problems. And here we need to also remember there could be non-chromosomal associations like evolving bowel problems, or it could be even a marker for genetic disorders, especially cystic fibrosis, or it can be a pointer for evolving fetal growth restriction. Hence, whenever we see this, we strongly recommend the parents to come for follow-up both in the antenatal as well as sometimes in the postnatal period if required. So, dilatation of the renal pelvic ectasis is called as, renal pelvis is called as renal pelvic ectasis. And this is not again synonymous with hydronephrosis, because hydronephrosis we do see calyceal dilatation, whereas in renal pelvic ectasis it is only the renal pelvis which is dilated. And if there is associated calyceal dilatation, then we are going to call it as hydronephrosis. So soft marker is going to be only renal pelvic ectasis, and it's not going to be renal hydronephrosis. The implications are totally different for both of them. So the measurement must be done only in the AP diameter as shown in this picture. The cutoff varies for second trimester and third trimester. And mild pelvic ectasis could be a marker for chromosomal abnormality, especially Down syndrome. And the non-chromosomal concerns include conditions like pelvic-ureteric junction obstruction or vesico-ureteric reflux. Hence, all these babies require both antenatal as well as postnatal follow-up. So this is just an interesting patient where there was mild right pelvic ectasis noted at 18 weeks, and on follow-up, we could see that at 23 weeks, the baby had dilated ureter as well. So we counseled the parents appropriately, and we followed the baby. And postnatally, we got the ultrasound, and it showed that we can see in this picture that the lower portion of the ureter is a bit dilated, and obviously this is a vesico-ureteric reflux. So if we had not followed up this baby after 18 weeks scan, we would have missed this. Whenever we see renal pelvic ectasis, I strongly recommend these babies to come for a postnatal scan, because we all know that all these are treatable conditions and the outcomes are going to be excellent. So next marker is going to be the skeletal soft markers, which includes both short humerus as well as short femur. So whenever we come across this, we also look at the shape and mineralization of the baby's bones. And if that's all normal, then we are just going to call it as a short femur or short humerus, depending upon the measurements we obtain in a fetal scan. Sometimes this could be a normal variant also. But when we see this, we need to think of chromosomal problems. We need to think of evolving fetal growth restriction. And sometimes it could be even a marker for skeletal dysplasia. And if we are ruling out all these above causes, then we can see whether it is a constitutional smallness, and we can follow these babies at a serial interval. Next is single umbilical artery. Single umbilical artery, generally we expect 3 vessels in the umbilical cord, which is 2 arteries and 1 vein. And some babies do not have one umbilical artery. That's called single umbilical artery. It can be either the right or the left, which could be absent in these babies. What we are worried about these babies is like whether the baby could have a chromosomal abnormality. And if we are able to rule out other systemic abnormalities, and if we are reasonably sure that all the other organs are normal, and if the aneuploidy screening suggests low risk for chromosomal problems, then we are reasonably safe, and we encourage these parents to come for a follow-up. And we ask them to come for a serial growth scan at 4 weekly interval, because there is evidence to say that these babies could potentially become growth restricted during the later part of pregnancy. So serial follow-up is always recommended, and these babies with an isolated single umbilical artery do have excellent postnatal outcome. They do not have any postnatal sequelae at all. So what are we going to do when we find a soft marker in the ultrasound? As I mentioned, whenever we see unusual in a fetal ultrasound, I think it's worth sending the mother for a proper detailed anatomical survey with a proper fetal echocardiogram for a tertiary scan, and then to make sure that everything else is normal and the parents are counseled well about the finding, and so that they have to understand what is happening in the baby. So it's a good chance that we can talk about all these evolving problems also, which are very much treatable when picked up at the right time. So when it is isolated, single aneuploidy marker, we're just going to stop evaluating at that point in time. And we have to also look at the chromosomal aneuploidy results. And as I mentioned, if it is low risk, then we are reasonably sure that the baby is fine. So moving to aneuploidy screening, chromosomal abnormality screening or Down syndrome screening, it could be of varying types, by which I mean that it could be performed in the first trimester, in second trimester. What we generally stick on to now is the first trimester combined screening, and we reserve the second trimester aneuploidy screening quadruple marker test for women who have missed the first trimester ultrasound combined screening. And when it is positive, again, we need to send the mother for a proper anomaly scan and a fetal echocardiogram, so that they can be counseled from there whether they have to undergo further direct invasive testing or not. And when a woman had a cell-free DNA test or non-invasive prenatal testing for chromosomal aneuploidy, and if it turns out to be a positive result, then definitely this requires further confirmation by amniocentesis. So we have been talking more about chromosomal problems and all the soft markers which we have been discussing, where in the context of chromosomal problems, essentially they have been discovered to identify a chromosomal abnormality in a fetus. But is this enough, or is there anything more? So I think we also have to remember that whenever we come across a chromosomal abnormality, I mean a soft marker in the fetal ultrasound, we need to remember about evolving problems and strongly advise the parents to come for postnatal follow-up. So this is how I would like to classify the findings. Findings which are expected to be not of concern are echogenic intracardiac focus, isolated choroid plexus cyst, and isolated single umbilical artery. Remaining all findings, all the other markers will be considered as findings of concern, though we are not going to press the panic button to the parents and we are going to tell them the outcome is going to be good, but still they all need follow-up to pick up later evolving problems. So soft marker could represent chromosomal abnormality, non-chromosomal abnormality. So when we are reasonably sure about the baby is chromosomally normal, then we need to think of evolving abnormality. Again, I would classify this into structural evolving abnormality or a growth abnormality like fetal growth restriction. And there is always a small subset of genetic disorders which we have to bear in mind. Though it is not common, I would say that we quite often we come across all these parents, and whenever we suspect all these, we need to work up these couple. We have to get a proper pedigree, and we need to look at the old records if they had any bad obstetric history. When we find a soft marker in fetal ultrasound, there's something beyond the chromosomal problem or Down syndrome. So we need to follow up these babies. It's because there could be some evolving abnormalities like structural fetal problems, abnormalities, or fetal growth abnormality like fetal growth restriction. So I think the answers for many of these questions which we have in our mind as imaging specialists, as pediatricians, neonatologists, all these could be answered only when we have a proper postnatal follow-ups for these babies. So whenever there is anything abnormal in a fetal ultrasound, and if you think that it's Downs, and if you rule out it's Downs, still please don't stop till then. These findings could be subtle markers for some other evolving problems or points of concern which could be very much be amenable to treatment in the postnatal period. Hence, recommend postnatal ultrasounds for these babies as per the antenatal findings which you come across during the anomaly scan or a growth scan. So I think bridging this gap is very, very important. Fetal imaging specialists or fetal medicine specialists should closely work with the pediatric specialists and neonatologists. And this helps us to understand a lot about the pathophysiology. Thereby, again, it helps us to give a proper counseling for the parents during the prenatal period. So my carry-home messages would be a positive ultrasound marker for aneuploidy will definitely need a proper detailed anomaly scan with fetal echocardiogram. Any unusual minor marker or a soft marker needs follow-up, and postnatal follow-ups helps us to understand the pathophysiology better. Also, of course, it's going to help the babies whether, for example, if it's going to be a renal pelviectasis, we need to rule out that it's not progressing to vesico-ureteric obstruction. And whenever we see an ARSA, then we need to rule out a vascular ring. These findings are not going to present as medical emergencies in the newborn period or in the infancy period most of the times. But still, it's a good opportunity for us to identify these findings in the antenatal period, so that this can help the baby a lot as far as the outcomes are going to be concerned. Counseling plays a major role, not just for decision making, but also for making the parents come back for a follow-up. So at Tiny Hearts, we have been lucky to work closely with all the pediatric subspecialists. So with pediatric cardiologists and pediatric neurologists, neonatologists, and pediatric surgeons. So we are really happy that we were able to make a change as far as the awareness part is concerned. And in the past 2.5 to 3 years, we have treated almost 1,000+ kids with various congenital heart problems, structural problems, rhythm abnormalities, complete heart blocks, and surgical problems. So HRIDYASPANDANA is our not-for-profit organization which focuses on helping the newborn and children with congenital defects or birth defects. And every child is a blessing. I think all these children where the outcomes are going to be really good, and we need to identify at the right time, and we have to help all these kids. That's our primary idea of doing all these in such a small city in India. So thank you very much for your patient listening.
Thank you, Dr. Usha. You can stop sharing now. That was an amazing presentation, and it's really amazing work that you are doing, both of you, as well as this foundation that you have. I hope it flourishes and you're able to serve many more patients, especially the needy ones. And you have a good support. You mentioned that you have pediatric surgery and you have NICU as well, and the growth restricted babies and things you have, you're able to follow up yourself as well. So well done, and best wishes for great successful progress with this. Coming back to the discussion, I mean, in terms of so we have many scenarios. We have a parent who, for example, they have done, I mean, can you mention a couple of words about double marker and quadruple or triple marker as well?
Yeah. So actually, what is being done in the first trimester is called a first trimester combined screening. So I prefer to use the term first trimester combined screening because double marker means we look at 2 markers, beta HCG and PAPA in the mother's blood. Whereas when you say it's combined screening, it's going to integrate the nuchal translucency measurement as well, and even the presence or absence of the nasal bone, etc. So the appropriate term would be first trimester combined screening, which is done between 11 to 14 weeks. And this NT measurement should be done by a proper imaging specialist so that we can reduce the measurement errors as well, which is going to bias the final risk. And preferably, we ask the mother to give the blood on the day when the NT scan is performed. So, and the report is going to say whether the baby has got a high risk for Down syndrome or low risk for Down syndrome. The accepted cutoff is again when it is less than 1 in 250, we call it as high risk. And then again, these mothers are subjected for a proper early second trimester ultrasound, I would say. And also they have to be counseled about this meaning for this high risk in the double marker or first trimester combined screening. We need to give the options of further testing for these mothers, as you know. And in second trimester, as of now, the detection rates are much better for first trimester combined screening than for second trimester aneuploidy screening. Essentially, triple marker screening is in vogue, I would say. We are not using it in our practice. So instead, there's something called quadruple aneuploidy screening. So that is reserved for women usually who have missed the first trimester screening, and because the detection rate is lesser as compared to the first trimester combined screening. Whereas the counseling part for this also remains the same. If it is high risk, again, we have to talk about the presence of any soft markers or any major or minor congenital abnormalities. And we have to ask them to undergo further testing based on that.
So what are included in the quadruple testing?
So in quadruple marker test, we look at, as the name suggests, there are 4 hormones which we are trying to look at. One is beta HCG and alpha fetoprotein and unconjugated estriol and inhibin A. So these are the 4 hormones we try to look at in a quadruple marker test.
The reason it's not as reliable is because it can fluctuate with the growth and the timing, the dates and things like that.
Yes.
And I mean, so you did the first trimester combined testing and it's abnormal. So would you ask for an NIPT or would you ask for a chorionic villus sampling in these cases?
Okay, so that's again a good question, and I think it's like when there is an increased risk alone, when the NT is normal, if we can just assume that the NT is normal, the nuchal translucency is normal, the nasal bone is present, and the baby is completely structurally normal, and after that, if the woman gets a positive high risk report for first trimester combined screening for Down syndrome, then again we call her and counsel, and we tell her that this is the possibility of the baby having a Down syndrome, and we give the options of cell-free DNA testing or NIPT. And we also, I also talk about the direct confirmatory test. And one thing about NIPT is till date, like even if the NIPT is going to be positive, the confirmatory test is going to be the direct fetal testing. So I put all these options to the patient.
Just for the benefit of those who don't know NIPT, I mean, basically it's non-invasive prenatal testing and you're harvesting the fetal cells from the mother's blood. Is that right? And then you are looking mainly for the trisomies and the sex chromosome abnormality. You can't look at the wider genetic picture. So that's why it rules out the trisomies to some extent. The sex chromosomal abnormalities are not as reliably ruled out. Maybe a 5 to 10% chance of missing them or having a false positive result.
Yes.
And in terms of,
increasingly there have been labs which are coming up with cell-free DNA testing for even all the chromosomes. But still, up to my knowledge, until whatever the evidence says as of now, it's still going to be a best screening test, and it's not going to replace the direct fetal testing.
What about the turnaround time?
The turnaround time, usually it is like here, I would say like in India, it will be maybe around 7 to 10 days.
And if you do CV?
Sorry?
If you do chorionic villus sampling and send
chorionic villus sampling, again, depends on what we are going to test. If it's going to be a PCR or a FISH for the common aneuploidies like chromosome 21, 18, and 13, it's going to be like maybe 2 or 3 days. And if it is going to be like, if we are ordering some other test, whenever there is additional ultrasound finding, which could point not just the chromosomal numerical aberration, which could, in case if it's going to represent even the possibility of chromosomal structural problems like microdeletions and microduplications, we go for microarray analysis or CMA, and that takes about a week's time.
And in terms of cost implications for these, I mean, I know it will vary from center to center, but a ballpark figure for these genetic testing, I mean, will you have the option to do the PCR or the FISH first? And if it's negative, you can ask for the whole genome sequencing or anything like that?
Yeah, there are multiple options available.
The same sample can be used for the, you can go step by step in terms of.
Yes, the same sample can be used for all these testing.
Is it going to cost like 20,000-30,000 rupees or more?
In India, I would say like for if it is going to be a PCR FISH along with the karyotyping, maybe around maybe 15,000 or so.
Genome sequencing or microarray?
Genome sequencing costs much higher than this. If it's going to be clinical exome, or if it is going to be whole exome or whole genome, the cost varies. So I would say approximately those all fall. It depends, varies from lab to lab, and maybe it's usually more than 20,000.
Becomes very difficult, and also sometimes you get results on those which you can't interpret as well.
Exactly. Yeah.
And in the terms of amniocentesis, if you have decided not to do the CVS in the first trimester screening and your concerns persist, you would go for amniocentesis. Apart from this, I mean, the soft markers will add to it, I suppose, in the second trimester. Most of these soft markers on the scan, you are looking at the 12-week scan or the 20-week scan?
The so-called soft markers which I had mentioned about and we have been talking about so long is it's restricted to second trimester scan. Yes, second trimester scan, anomaly scan. So we can see all these findings as early as from 16 weeks onwards.
Yes. So
in our center, we do early anomaly scan from 15, 16 weeks onwards, and we can even do fetal echocardiogram from that point onwards. And so essentially, it's all restricted to second trimester. All these markers we are going to look at all these markers in the second trimester.
Let's take one scenario. A parent has single umbilical artery diagnosed in your 16 or 18-week scan and no other anomaly. Is it reasonable to say that it's adequate to monitor? You're probably done the early pregnancy screening, which is negative as well. So it's adequate to reassure them and monitor the growth of the baby, right? Some cases you get IUGR and your monitoring will be adjusted to that level.
Absolutely. In that scenario, even I would say we'll just wait and do a follow-up scan to look for just baby's growth.
Yeah. And it's when you have choroid plexus cysts, I mean, does the number of cysts or the laterality matter much? If the rest of the results are normal, can we still be as strong in reassuring them? If there is few cysts on both sides, it's the same implication, I suppose.
Exactly. It's the number of cysts, the size of cysts, everything. When we say it's isolated, it's always innocent. So it doesn't vary with the numbers or the size or laterality, whatever.
So for the parent's perspective, I mean, a choroid plexus is just the area of the ventricle, which is the fluid-filled area of the brain where the fluid is produced. It doesn't have brain-related function. It's more a supporting tissue. And so if there is a cyst there, it doesn't mean the brain has a hole. So don't be panicking. And this is a soft marker as we discussed in the beginning. In terms of echogenic bowel, one of the theories is that in the early first trimester, some blood may be swallowed, like a threatened abortion or something like that. So that can be a common reason for the echogenic bowel as well, isn't it? So if your repeat scans are normal, you can follow them reasonably.
Yes. Having said that, that's what I think every patient is different. So sometimes I have come across patients where echogenic bowel turning out to be a real anorectal problem, or even when we elicit a proper history and when we look at the consanguinity and the pedigree and all those, I have seen even cystic fibrosis running in those families. But of course, they are not the major number of patients who are going to be in that category. But still, I would like to keep all those in the back of my mind when I counsel those parents.
If you have bowel dilatation as well, it becomes more significant, I suppose.
Exactly. If it is bowel dilatation, it's definitely pathological. It's not going to be.
Is it clearly defined, the dilatation? How much is the size and so on? You have criteria.
There are again various cutoffs and all those, but
gestation dependent.
It's gestation dependent, and we can look at the peristalsis also. We can see some calcifications in the bowel or even ascites and all these we see. So when I say it's echogenic bowel, I'm just going to stick to only the echogenicity of the bowel, considering that the loops are not dilated.
Yes.
So it's only the echogenicity of the bowel.
I mean, just one last question. I mean, I know the radiologists and the fetal medicine experts use software provided by different companies, and it may be standardized with culture, I mean, different ethnicity groups and so on. You have worked in India and Australia as well. So, I mean, to what extent does this variability affect your outcome or the results?
You mean you're asking the ultrasound?
Suppose you have a femur length or the growth measurements and the centiles that you say, I mean, these will have thresholds depending on the ethnicity and things as well, isn't it?
Yes.
Because,
Yes. I think when we perform scans here, we always stick to the nomograms which have been designed for Indian women. Yeah. So I think that plays has a role. So especially when all the Western charts, sometimes they do not correlate well. So here in India, I do stick to the nomograms which are specifically studied Indian women, and based on that values.
Amazing. I mean, so we have covered a lot of information, and obviously I'll share this video as well as snippets from it to cover the different topics that we discussed. I mean, I'm sure this will be useful for the pediatricians, obstetricians who are watching and interested in fetal medicine. And obviously, I'll share your email address as well if you're okay with that. So if anyone wants to link up with you directly, it's fine as well. Really appreciate your taking the time to discuss this with us today. Thank you so much.